Hello, everyone. Good morning. Actually, good afternoon. Welcome to the LMP U of T Hematopathology Community of Interest meeting. Today, our discussion topic is discussion of the current hematopathology practice in the light of WHO 5th edition ICC 2022 classification. My name is Dr. Sadaf Memon. I'm the pathologist at Mackenzie Health. So I will be introducing our first speaker, Dr. Rosemarie Tremblay-LeMay, the assistant professor at University of Toronto. She will be discussing the results of the survey that you have all kindly filled out. Rosemarie, I'll share your screen.
Yeah, thank you, Sadaf. So first of all, thank you to all the people that responded to this survey. So this is, just to clarify, this is meant to be just like a short little survey to serve as a conversation starter to discuss something our group that organizes the community of interest have been thinking about, and get the feedback from the members. And so there were 15 responses. And the first question was, are you familiar with the two publications outlining the WHO 5th edition and the ICC 2022? And 80% of people were familiar, 20% said they were not familiar. I imagine they're aware, but perhaps haven't yet sort of fully reviewed all the changes. And I think, it probably just reflects the different practices and whether sometimes people have many different in community centers are doing many different things. So that was the first one. And currently, what diagnostic criteria do you use in your pathology reports? And so there was a lot of variability. So 20% still use the 4th edition, 60% are now using WHO 5th edition. Nobody uses the ICC only. 13% give both the WHO 5th edition and the ICC 2022. And 7% will give 4th edition, 5th edition, and the ICC. So, just interesting to see that we're in a time of change. And so there's a bit of variability in terms of how people have adapted so far to these new classifications. The other question, we'll just look at this kind of more broadly. It was to get a sense of, which stains are available, like how many stains are available to people as they practice. And just the thing to kind of derive from this would be that there's, again, a huge variability in terms of what people have access to when they are working up those hematopathology cases. And finally, we kept it simple and just ask in terms of molecular. We didn't start to kind of distinguish which types of molecular tests, but just in general, basically 30% roughly have most tests available within their institution. 13% have some tests, but around 50% of people have to send out all cases for additional workup. So I thought it was just interesting to kind of a little bit get a sense of what's happening and the types of practices. And this just brought us to our idea. Now that we have these new classifications, and obviously the classifications outline, those criteria, diagnostic criteria for each entity, but it's always when you're facing a case, let's say you have like a small B-cell lymphoma or you have a large B-cell lymphoma, just have a bit of a consensus on what would be kind of a reasonable workup that most cases should receive, obviously still leaving room for individual pathologist judgment to adapt it, but have a bit of a kind of a starting point that we could kind of hopefully all agree on, and perhaps could be a bit modeled on what WHO has done in terms of this is sort of the essential, this is kind of a nice to have if it's easily accessible. And hopefully it could be helpful to people to have access to a document like that. And so we just wanted to make sort of a call for interest. whether you're an academic or community center, and actually we would like to have people from community centers joining and bringing their perspective, that would be interested in forming a working group to kind of look at those new classifications and thinking, okay, which tests are available, which tests are currently reimbursed, where are they accessible, and just produce a document that would be outlining kind of what's sort of reasonable workup in terms of immunohistochemistry and cellular testing when we are working up hematopathology cases. And so, if you are interested in joining such a project, just contact either myself or any of the other members of our group, Sadaf, Sarah, Rashmi, and Adam. And based on how many people express interest, we could look into developing this further. So were there any questions?
Thank you. I have a question.
Yes.
Do you think that the hematopathology cases, I mean, all the hematopathology cases should be sent to hematopathologists from the start? I mean, when you sort out that this is leukemias are out of question. I mean, the lymphomas. Do you think that we should work the case as a non-hematopathologist or just send them as soon as we think that this is a lymphoma?
You're giving me a very tricky question. I think it's hard to give sort of a one-size-fits-all statement, because I think it depends on individual people's level of comfort, whether they have a special interest in heme and they kind of enjoy sort of reading about it and they have a reasonable amount of case versus, you do one case once in a while and then it's a bit more difficult to you don't have access to all the tests and you don't have maybe all the immunos that one would like to be able to do. And I think it's also kind of balancing preserving the tissue now that we know we have so many things to do. So perhaps when there's not a lot of tissue, it makes sense to send it out so that things can be triaged. But to say whether everything should be sent up front to reference centers, I think just logistically in terms of volumes, I think it's something that we need to be kind of organized if that is where we want it to go. But I still feel like there's a certain kind of, it's reasonable to let people decide if they feel comfortable and if they want to work it up versus if they would prefer to just say, I think it's best to just send them out. So I don't know if other people have different opinions, but yeah, I would say as long as you feel comfortable that if there's not a lot of tissue, you're not going to have to kind of do tests that end up not being entirely necessary. So yeah, what do you think?
I really want to know like what the experts think, because what I see is that this is the subspecialty in pathology, nearly the only one that people started to get away from it if they are a general pathologist. Like the general pathologists work out everything. Like they work gynae, they work out breast, they work colon, they work out every case. And if they need, they send it. But I feel that there is a certain, not impression, or maybe, I don't know, I practice in many countries, but I feel that in Canada, like it is very peculiar that the pathologists are running away from the hematopathology, I mean the lymphomas, so quickly, and we are losing our skills, specifically in lymphoma, like apart from any other subspecialty. That's what I'm asking the experts, if they really think that this is the right thing to do.
I can add a comment to it. I'm Sadaf. I'm the general pathologist, diagnostic and clinical pathologist now with their new name of the specialty. So my practice is half and half. So I do hematopathology as well as general surgicals. So as Rosemary indicated that if I see that the tissue is really minimal and then the markers in-house at my institution are less, then I would just save the tissue and send it as a consult, where I think that and or cut unstained slides and send it together. But minimally, I would do the basic panel, the workup, and for the molecular, we do send out to UHN. We do send our specimens and our for molecular and NGS, for especially for our bone marrows, we do send it to Sunnybrook. Dr. Hubert Choi, he's in the group right now, and he will also shed some light on that too. But I would say that, you know, if you're saying that you would lose your skills working in the general practice mode, I think you can still work on your case as far as you know that you have enough tools, enough immunohistochemical panel to work on it, and you can reach to the diagnosis. You can comfortably show to a second pathologist for your opinion and send it out for a consult. Okay, we can move on to our case discussion, and the current theme of the case discussion is the current pathology practice in the light of WHO 5th edition and ICC 2022 classification. So we have an interesting case from Dr. Sarah Morgan. And Sarah is an anatomical, trained in AP and hematopathology fellowship at U of T. She practices as a surgical and hematological pathologist at Oak Valley Health, previous Markham Stouffville Hospital site. Sarah, please take it away.
So this is a case, as Sadaf has introduced, that this is a case where there is some changes between the WHO 4th and 5th edition. And when I discuss the case, it will be highlighted with these differences. So last month, I got a case of a patient who is 66 years old, a male patient who had a visit to the ER twice, almost with similar symptoms, shortness of breath, fatigue, and facial swelling after a recent travel to Peru. His total blood counts showed leukocytosis and neutrophilia with some absolute basophilia, but the lymphocytes were within normal numbers or ranges. Hemoglobin and platelets were also normal, and the labs did show some confusing results like monoclonal protein, which by immunofixation came back as Ig lambda paraprotein. The beta-2 microglobulin, I'm sorry, there is a typo, were slightly elevated and the albumin was low. When the patient went ahead to do some imaging, the CT scan of chest and abdomen were done because the patient had the shortness of breath and they were thinking, will this be a pulmonary embolism or something infectious from his travel? But they revealed retroperitoneal lymphadenopathy and bilateral axillary lymphadenopathy, which were really bulky in size. So I got for this patient 3 specimens. Initially, I got the bone marrow aspirate in early October and bone marrow biopsy, and then I received a lymph node biopsy later in October. The clinicians were quite confused with the manifestations, the lab, and the CBC, and so the clinical question to me was exclude lymphoma or a myeloproliferative neoplasm. For the sake of time, the bone marrow aspirate did not have a lot of findings. I'll discuss them later, but I'll dig into the lymph node pathology. So I will talk now about the second lymph node, and I'll tell you why. The first lymph node biopsy that I got early October was insufficient for diagnosis, and I'll get into the details later. So I asked for a re-excision, for a lymph node excision, but unfortunately, it's very hard to book the OR in our hospital. So I got another core that was much better than the initial one, and I'll show you the findings that I had. So this is the right axillary lymph node biopsy, and as we see on the screen with this low power, that the lymph node architecture is effaced by an atypical infiltrate. On higher power or medium power, we can see that there is a lot of lymphoid cells that look monotonous. They are medium-sized to few ones that are larger inside, and there is some vascular proliferation in the background, but we don't see the B cell zones clearly. On a higher magnification, we can see the cells more clearly. They have medium to large size and a pale to clear cytoplasm. The nucleoli are inconspicuous, and there is minimal atypia, and we cannot appreciate any mitotic figures or any necrosis. This is the highest power which can confirm the findings and show the morphological features of the monotonous proliferation of lymphoid cells. So doing immunostains, I started with CD20. CD20 showed that there is some B cells that are seen mostly within lymphoid follicles, but the predominant population of lymphoid cells in the background is quite negative for CD20. This is a higher power of CD20 and the close-up of the area with the lymphoid follicles. And it's showing that the other cells in the background that are not B cells are kind of coming out or emanating from the lymphoid follicle and going out to the interfollicular areas. So I did CD3 from among my panel, and CD3 showed exactly what I was expecting from CD20, that I'm dealing with a T cell process rather than a B cell process. So I continued to do the rest of the panel, and the pan T cell markers are all strong positive, CD3, CD2, and CD5. The population of interest with the medium-sized cells showed weak staining for CD4, but the CD8 and CD7 showed negative staining on the cells of interest, and the positivity that we are seeing is just background reactive small lymphoid cells, but not the lesional cells. Furthermore, BCL6 and CD10, which is not shown on the screen, are negative. ALK is negative and TDT is negative, but BCL2 is positive on the majority of cells, of the T cells. Ki67 showed slightly high proliferative index of about 30 up to 40%. I went ahead and did the follicular dendritic cell meshworks markers, which are CD21 and CD23, and we have them both at our institute. And these are highlighting the same areas that were highlighted by CD20, and these are basically the lymphoid follicles that are residual in a background of no lymphoid follicles. A close-up view is also confirming the findings that the lesional cells are coming out of the follicular dendritic cell meshworks and spilling into the interfollicular areas. This is another view confirming the same findings, and also it's showing something interesting here, that the follicular dendritic cell meshworks have certain clear spaces in the middle which represent what we call high endothelial venules, or the vascular proliferations that I referred to. So these are entangled within the expanding follicular dendritic cell meshworks. So I'm showing again the area that had the lymphoid follicles, just to confirm again, this is CD20 showing these residual follicles. CD21 is highlighting the expanded meshworks. The lower left picture is showing an important feature in this type of lymphoma, which is the high endothelial venule proliferation. And CD3 is showing that the process we are dealing with is a T cell. This is another view of the high endothelial venules, which should be proliferating more pronounced than in a normal lymph node. And in certain cases, they have plum endothelial cell lining and hyalinization, which was not very clear in my case. That's why I didn't take a close-up view of that one. So among my panel, I have an IBER-ish at my institute as well. So IBER-ish was positive, and the positive IBER-ish is from the initial case that I said insufficient for diagnosis. That case had less features than what I had in this lymph node, but the IBER was the very only convincing feature or finding, and I wasn't sure when I got the initial biopsy if I'm dealing with an EBV-driven process like a B-cell process or a reactive process or a Hodgkin lymphoma, because I had some large cells with reactive lymph nodes, follicles, with nothing else that I'm seeing now in this current biopsy. I don't have follicular helper, T follicular helper markers in my institute, so that's what I sent outside. And I got PD1, which is strongly positive on all the atypical lesional cells. And it's also showing a nice feature that these cells are encircling the high endothelial venules, which look like clear spaces or negative staining for PD1 in this image. Another T follicular helper marker is the ECOS, and I sent that as well, and it came back positive. And the third one that I sent for was CXCL13, which had a different type of staining. It's usually a cytoplasmic or a perinuclear dot positivity, but it's very specific that any type of positivity would be considered positive. So this one would be considered positive in this case. And just to sum up the amount or the number of T follicular helper markers out there, so we have PD1 and ECOS are more sensitive. CD10 and CXCL13 are more specific but less sensitive. And if I have strong PD1, as we have in this case, and strong BCL6, which I don't have, these are also more specific. And at least 2 follicular helper markers are needed to make the diagnosis of a helper T follicular helper type T cell lymphoma. So in brief or in summary, the T cell lymphoma that I have had this immunophenotype, pan T cell markers, it's a CD4 positive lymphoma with T follicular helper markers, and everything else was negative. The meshworks were highlighted by CD21 and CD23. The KI was moderately elevated and IBR-ish was positive. A flow cytometry was sent on the same lymph node tissue, and it showed 92% lymphoid cells. 30% of them were atypical with a slight increase in site scatter and with basically similar phenotype as we got with our immunostains. So the diagnosis rendered on this case was nodal T follicular helper cell lymphoma, angioimmunoblastic type, and this is the new name as per the WHO 5th edition of 2022. And the previous name that we used to use for the WHO 4th edition was angioimmunoblastic T cell lymphoma. If we look at the WHO index, we will see that there are types of T cell and NK lymphoid proliferations and lymphomas. And among those, there are precursors and other types, but our lymphoma falls under the mature T cell and NK cell neoplasms. And this is a chapter called nodal T follicular helper cell lymphoma, which includes 3 types of lymphomas: the angioimmunoblastic type, follicular type, and a non-otherwise specified type. So the T follicular helper cells are the heroes of this type of lymphoma. And we all know that the T follicular helper cells are basically found in the germinal center of a lymphoid follicle. And they are really important for the function of the germinal center and its development. And they are also responsible for the production of antibodies and memory B cells. Despite the fact that we have histologically identified entities under the nodal T follicular helper cell lymphoma, there is quite a considerable morphological overlap and an inter-observer variability. And as we see here, this figure is from the WHO 5th edition, that they have a lot of overlapping features, and sometimes it's hard to tell which type we are dealing with. If we focus today, as the case I have mentioned is the nodal T follicular helper lymphoma angioimmunoblastic type. So this is defined as a mature T cell lymphoma. And as we mentioned on the immunostains, that this is a T follicular helper phenotype. And it's characterized by systemic disease and polymorphous lymphoid infiltrate and high endothelial venule proliferation, which are sometimes called arborizing high endothelial venules, and expanded follicular dendritic cell meshworks. It mostly affects middle and elderly patients, middle-aged and elderly patients, male slightly more than female, and it's considered as the commonest node-based peripheral T-cell lymphoma. In some books, it says it's 36% of the non-cutaneous T-cell lymphoma. The patients present as the patient I discussed today with generalized lymphadenopathy. They could have hepatosplenomegaly, skin or bone marrow infiltration, and they could rarely present with a leukemic presentation. So those patients are really sick and they present with a lot of confusing symptoms, constitutional symptoms, sometimes with fever. They always present with an advanced stage disease with generalized lymphadenopathy, organomegaly. Bone marrow is involved upfront in 70% of the cases. And they have a lot of immune dysregulation, and that's what made our case quite interesting or confusing initially for the clinicians. They can have all sorts of autoimmune hemolytic anemias, cytopenias, rheumatoid factor, cryoglobulinemia, hypergammaglobulinemia, even monoclonal spike, as our patient had the IgG lambda, and leukocytosis, eosinophilia. So initially, it can be really a challenge to nail it down into a lymphoma unless a lymph node biopsy is performed. Here I'm showing a summary of the histological findings of this type of lymphomas. So on the left side, I put from number 1 to 5 the main findings in this lymphoma. And you can look at the photomicrograph. It's showing a polymorphous infiltrate, which is predominantly made of small lymphocytes, immunoblasts, which are the ones with prominent nucleoli, plasma cells, histiocytes, and eosinophils. And sometimes this is quite confusing even for the pathologist because it looks like a reactive process, and the neoplastic T cells are usually a minority, quite often obscured by the endothelial venules that are proliferating or by this reactive infiltrate in the background. And the T cells, as we have shown in our case, are usually medium-sized with a pale to clear cytoplasm, and there is high endothelial proliferation, which is maybe looking better on the right side of the screen, the upper photomicrograph, and follicular dendritic cell meshworks are usually expanded. And the interesting thing is that B cells, also B cell immunoblasts, which are EBV positive, are a constant finding in about 60 to 80% of those cases. So the EBV that I've shown, the EBV positive, is not on the T cells, it's on the B immunoblasts, that because this is an EBV also driven process. The figure on the right is showing that these cases come in 3 flavors. They could be either pattern 1 or pattern 2 or pattern 3, which I will discuss more thoroughly in the next slides. But just here, because they are beside each other and easier to understand, pattern 1 is mostly looking like reactive follicular hyperplasia. Type 2 has lesional cells, but still some atretic follicles, while the third pattern is mostly diffuse lesional cells with no lymphoid follicles whatsoever. So this is pattern 1. These figures are from the WHO 5th edition, and it's showing basically reactive follicles, and the focus in those images is on one of them, showing this is a reactive lymphoid follicles, sometimes with the mantle zone is not very well showing. CT21 is highlighting the follicular dendritic meshworks within the follicle, but they are not really expanded. And the neoplastic T cells are inconspicuous and hard to diagnose in this type of in this pattern of lymphoma. So oftentimes we need immunostains like CD10 and PD1, as shown on the right side of the slide, to highlight that the T cells are arising from the lymphoid follicles and spilling into the follicular areas. But if you look at the gross picture or the low power view of those lymph nodes, the lesional cells are not in the interfollicular areas and are very hard to diagnose. Pattern 2 would be partial effacement of the lymph node, but with some residual atretic follicles, like the one seen on the left. And PD1 is showing also the T follicular helper lymphoma cells emerging from the follicle and spilling into the interfollicular areas. Pattern 3 is the full-blown picture with complete effacement of the lymph node by the atypical infiltrate that's shown on the left side, upper and lower photomicrographs. The pale and clear cytoplasm are seen. And then the follicular dendritic meshworks are really expanded, as shown by CT21. And then the 3 other photomicrographs are showing the T follicular helper phenotype as we talked about it, PD1, CD10, and CXCL13. There is something written in the WHO which was very helpful for me in this case, that the three patterns are sometimes overlapping in the same lymph node and sometimes in consecutive biopsies as well within weeks. So the initial biopsy that I got was mainly pattern 1, and it was very hard to make a diagnosis of a T-cell lymphoma based off that one. When I got the second lymph node biopsy, this was about 4 weeks later, and I wouldn't say that I have pattern 3 completely, but I have pattern 2 and pattern 3 both together, because I had areas with diffuse lesional cells, but other areas, as I have shown initially, with still residual lymphoid follicles, and the CD21 and CD20 were highlighting those follicles. So I think my pattern was 2 and 3, but it was very different from what I got in the initial one. The immunophenotype is shown on the screen exactly as I said before. There could be some losses of CD markers. I don't think I have a slide for that, but I had the CD7 loss in my case. No, I think I showed it with CD4 and 8. So there could be some losses, like CD7 could be lost. There could be dim expression of some T-cell markers, like the surface CD3 could be dim on flow, and it was dim in our case as well. These are mostly CD4 positive, rarely CD8 positive process. And the T follicular helper markers, we need at least 2 to identify this type of lymphomas. It depends on the availability in your institute, but CD21, 23, and 35 are very helpful to show the significant and important feature of the follicular dendritic cell meshwork expansion. And these are encircling the high endothelial venules. If you want to show your B immunoblast, you can use CD20. CD30 is sometimes positive on those cells, and IPER-ish is very helpful to show that this is an EBV-driven process. The polymorphous background, as shown in our case, could be a mixture of CD8 and CD4, but mostly CD8. So the WHO is also showing that in those cases, we need to have essential and desirable criteria, as mentioned in every single entity of the WHO book. So in pattern 2 and 3, we need a nodal disease, CD4 positive process, extrafollicular dendritic cell meshworks, expansion, and high endothelial venules, which we had all of them in our case. And the desirable ones, more than T follicular helper markers, clonal T-cell rearrangement, which I sent for, but I haven't gotten back yet, and EBV positive B cells, which I had as well in my case. In pattern 1 and 2, it's somehow more difficult to make a diagnosis. So the WHO is mentioning if you don't have the criteria fulfilled, you can ask for a rebiopsy because the sampling is insufficient. T-cell rearrangement is the main molecular test to go for. There are also some genetic markers like the IDH2 and other ones, but it's not in our scope today. So finally, the staging for those cases is using the Lugano modification of the Ann Arbor staging, and those patients don't usually do well. They are really sick, and the prognosis is dismal. So the 3-year survival is about 50%. There are certain features which will portend more of an adverse prognosis, like the male sex and certain concurrent genetic abnormalities. And the prognostic index used is something very relevant to the nodal follicular helper as opposed to the international prognostic index. Thank you. That's the end of my case, and I'm happy to take any questions.
Great. Thank you so much, Sarah. That was really interesting. Any questions? Okay, sure. All right, thank you. So I'll move on to the next talk, which was from Dr. Arij Khatib, but I think she just put a message that there is a code red. So I'm going to go next and present an interesting case that I came across. All right, are you able to see my screen? Okay, my name is Sadaf, and I'm a diagnostic and clinical pathologist at Mackenzie Health. I also serve as an assistant professor at McMaster University in the Department of Pathology and Lab Medicine, and I serve as a germ pathology section chair at the Canadian Association of Pathology. Okay, so I'm going to present a case. So 17-year-old female presented to the eMERGE with left-sided throat pain for 1 day. There were no associated fever or chills, but she was complaining of mild rhinorrhea. The patient was started on antibiotics and was seen in the ENT clinic with some improvements. However, 1 month later, the patient came back again to the emergency room with difficulty swallowing, nasal regurgitation of fluid, loud snoring, dyspnea. However, she did not present with any constitutional symptoms of fever, night sweats, or weight loss. There was no family history of hematological malignancies. She's a non-smoker, no alcohol use, and on physical examination, it showed a large left tonsillar mass, about 4 centimeters, that passed the midline. Sorry, there was an overhead announcement. Okay, the staging CT did show enlargement of the right pharyngeal tonsil. However, there was no lymphadenopathy in the neck, chest, or abdomen. So this is the scanning power of the tonsil, and we found. So the tonsillar architecture, as you could see, is effaced by a vaguely nodular to diffuse infiltrate. And so you can see still on the left side that there is some retained normal follicles. This is the higher power of 10x. And over here, you can see that diffuse infiltrate of intermediate to large size lymphoid cells. And over and to the next higher power, you can see that these lymphoid cells have open chromatin and multiple small nucleoli. You can notice that there are frequent mitosis and tingible body macrophages. Of note, there is no starry sky. Associated in the previous image, you see that the surface, there is no increase in intraepithelial lymphocytes, but you see that there is surface ulceration. So flow cytometry studies was performed, and it revealed that this was a CD5 negative, CD10 negative, lambda restricted monoclonal B cell population. So the flow panel, this is CD3 on the left and CD20 on the right. So we are dealing with the B cell lymphoma based on this. And this is the complete panel. And I'm sure if it's projecting well. So you can see that 3 and 5 have the similar kind of co-expression, just highlighting the reactive T cell. CD10 is DIM positive. CD20 is completely positive with diffuse architecture. CD23 shows the disrupted and very few remnant follicular dendritic meshwork. Ki67 MIB1 is very high. Cyclin D1 is negative. BCL2 was vaguely positive, and MUM1 and BCL6 were positive in this. So BCL6 was 100% positive, and MUM1 was 100% positive. BCL2 was about weak positive, about 30%, and it was lambda restricted. So applying Hens algorithm, CD10 was weak, BCL6 positive, and MUM1 positive. So time for quiz. So if you had to prioritize one test at this point, which one test would it be? Sure, so about 56% indicated that fish for gene rearrangement could be sent, about 6% MYD88, fish for IR4, 19%, which is very interesting, and fish for BCL2, 19%. The next step, which I did for my case, was I contacted UHN molecular lab, and I sent this case because I had enough amount of tissue, and this was an excisional biopsy. So I sent it for FISH for IRF4 gene rearrangement and DLBCL large reflex panel. So FISH for IRF4 gene rearrangement is available at SickKids in Canada. So the large B cell reflex panel came negative. So I ordered a reflex panel. So in the reflex panel, make BCL2 and BCL6 break apart requested. And so basically in the reflex panel, if MYC is negative, BCL2 and BCL6 won't be tested. So I just ordered the reflex. So MYC was negative. So the BCL2 and BCL6 were not tested. And interestingly, the IRF4 rearrangement panel showed the presence of IRF4 gene rearrangement. So discussing about this large B cell, so the overall diagnosis was large B cell lymphoma with IRF4 gene rearrangement. What is it? And according to WHO 5th edition, it's a large B cell lymphoma with IRF4 rearrangement is a de novo mature B cell lymphoma with follicular and or diffuse pattern, and it is defined by strong expression of IRF4, i.e. MUM1, usually due to IG and IRF4 translocation. The essential and the desirable diagnostic criteria, according to the new WHO 5th edition, essential are intermediate or large cell morphology, follicular or diffuse pattern. So in our case, this was residual follicular, but mostly it was diffuse. Mature B cell phenotype, so it expressed all the B cell marker, but it interestingly expressed BCL6 and MUM1 together, which is the essential criteria for this entity. The IRF4 translocation, if IRF4 rearrangement analysis cannot be performed, the proper clinical setting in combination with typical immunophenotype allows the diagnosis, but not molecularly confirmed. The desirable criteria is evidence of IGRF4 translocation and absence of BCL2 and MYC gene rearrangement. So it is localized. So where it is located, usually it involves the Valdeir ring or the cervical lymph node, as in the case, 17-year-old female presented with the tonsillar enlargement. Less commonly, it involves the pear patches or intestinal lymph nodes or any other site. And most patients in these population, they have localized disease. How they present? They usually present with asymmetrical tonsillar enlargement or isolated cervical lymphadenopathy without B symptoms. So my patient presented without any B symptoms, just like a reactive tonsillitis. So usually it is overall a very rare, representing about less than 0.1% of the large B cell lymphoma. The prevalence is low in adult patients, and most commonly it is reported in children and young adults with slight male predominance. The etiology is unknown. On immunohistochemistry, as I said before, it's a mature B cell phenotype with strong expression of MUM1 and BCL6. CD10 and BCL2 are expressed in about 50 to 60%. In my case, it was very weak positive. And CD5 is observed in about 30%. And Ki67 proliferation index was very high, as we observed in our case. So screening for IRF4 translocation is especially indicated in large B cell lymphoma with simultaneous expression of BCL6 and MUM1. So whenever you see in a case, right age, right clinical setting, and if you see that applying to health algorithm, when you see BCL6 and MUM1 co-expression, this is something to think about. And now we do have a test available in Canada as well. So that you can easily refer for IRF4 gene rearrangement studies to exclude or include your diagnosis. So as mentioned before, chromosomal translocation, it most frequently involves the IGH locus or rarely IG kappa or IG lambda, which can sometimes be cryptic, although it is rare, but cases with IRF4 gene rearrangement, so molecular cytogenetic methods can detect that. Interestingly, BCL2 and MYC are virtually never rearranged. We never use the word never in pathology, but in this case, BCL2 and MYC are virtually never rearranged. And whereas chromosomal breaks affecting the BCL locus have been reported. So how do you stage it? It follows according to the revised International Pediatric Non-Hodgkin Lymphoma Staging System, or the Lugano staging system, the prognosis and prediction. So the overall outcome seems favorable with rare relapses after adapted chemotherapy in pediatric or young patient. And interestingly, there's limited data are available to consider treatment de-escalation. However, several pediatric cases where there is entirely follicular disease or disease that have been described as apparently cured by the resection only. So the staging marrow was done for this patient, and it came to me. So there was the marrow was not involved. However, I did send it for for the molecular testing. It was positive. So there was a very minimal involvement of marrow but not detected on flow, but molecular was very sensitive in detecting that on the aspirate. So what is the differential diagnosis? We always wonder. So pediatric type follicular lymphoma, by definition, should lack IRF4 translocation and involvement of the extranodal tissue. The other important differential is follicular large cell lymphoma, and it usually occurs in adults greater than 40 years, might express MUM1, but if you send it for IRF4 gene rearrangement studies, it lacks the IRF4 translocation, so you can exclude that through that. Interestingly, other neoplasms do show IRF4 translocation, which are plasma cell myeloma, chronic lymphocytic leukemia, and several T-cell neoplasm, but they display a different histopathology. So ICC 2022 also recommends testing for IRF4 alteration in patients with follicular 3B expressing MUM1, especially in the younger patients. Large B-cell lymphoma with IRF4 rearrangement upgraded now to define an entity is most commonly seen in children and young adults, and usually has at least a partially follicular growth pattern. So we do see partial follicular growth pattern in our case as well. However, the same disease is not commonly seen in adults. FISH for IRF4 must be performed for diagnosis. So that is an essential criteria from WHO5 as well as from ICC 2022. Patient lacking the demonstrable rearrangement should have evidence of either IgH or Ig kappa, Ig lambda breaks. So detection of IRF4 mutation will support your diagnosis. IRF4 rearrangement can occur in other aggressive B-cell lymphomas associated with BCL2 rearrangement or MYC rearrangement, mainly in adults. And in this context, it is not specific for this entity. And with that, I would like to thank everyone for your attention. Any questions?
Sadaf, I have a comment on the case. That's a very interesting case. I don't think I've seen it before, or maybe I've seen it one time in my fellowship. My comment is so that people don't get confused. If a patient, if you do the Hans algorithm and the case is losing CD10 and expressing BCL6 and MUM1, this can happen in a lot of scenarios where it's an activated B-cell phenotype. But the most characteristic thing, as you showed in your case, Sadaf, is that the MUM1 is 100%, which we don't usually see. We see it around 30% to 60, 70%, but the presence of 100% MUM1, and as you said, the right clinical context of a young patient with head and neck lymphoma makes it more valuable to send this patient for IRF4. And thank you for mentioning this. I didn't know that sick kids had this rearranged.
Right.
Nice
No,
case.
great. Thank you. So yeah, so the key is BCL6 and 100% and MUM1 were 100%, and BCL2 in this case was up to 30%. So we do see cases for a large B-cell lymphoma that we commonly see that MUM1 is expressed and BCL6 is expressed, and then where do we go? Do we say it is GC origin? along with CD10 positivity versus do we say this is activated B cell origin. But the cutoff for IRF4 gene rearrangement is MUM1 and BCL6. You see it's full house. So I contacted for the molecular lab, and I had this case with Rosemarie, and she and we worked on this together. And she said, we can actually do this testing over here at SickKids in Toronto. So so here it is. And I did have another case as well where there was co-expression of BCL6 and MUM1, but that was an older patient. In that, we did not see any of the IRF4 gene rearrangement. So it was an interesting finding. Great. Thank you. I'm not sure, Jenny, if you can see if Dr. Arij Khatib from University of Saskatchewan, is she back? Yeah, so unfortunately, there was a code red and they had to evacuate. So, okay, so we have Dr. Hubert Choi online as well. And Hubert has kindly agreed to share an interesting topic, which is CCUS versus MDS, so clonal cytopenia of undetermined significance versus myelodysplastic syndrome. So Hubert, this is such an interesting topic, and we all wanted to learn from you. Thank you.
Thanks, Sadaf. I actually have a couple of cases. I might start with a different one first, but if there's time and people want to talk about MDS versus CCUS, we can do that one as well.
That would be great, Hubert. We have about an hour and 4 minutes, so we have enough time.
Okay, so so this one that I'm going to present today is again modeled off a real case, and hopefully we can get some discussion. I guess we're shifting gears here a little bit to the myeloid side now. So, so I was saying this is a young female referred to hematology for very mild leukocytosis and thrombocytosis. So you can see the white count is 12.8 and a little bit of a thrombocytosis at 417. Again, was incidentally found during the context of a new type 1 diabetes diagnosis. Otherwise, the hemoglobin levels are normal, as well as the hematocrit. There was nothing pertinent on physical exam. And so this may actually be a point of discussion on the clinical side for those who want to engage in it. So there's obvious things that you can work out. Let's just repeat the CBC. Let's rule out inflammation as a cause for the increased white count and the increased platelet. Now, I'm not sure how many pathologists on the call are also active in from a utilization aspect, where, as you can see at the bottom here, a clinical decision was made to pursue molecular testing in this with this presentation. So does anyone want to have a conversation about that, or just, maybe just put your thumbs up icon if you feel like, that's typically what you're seeing at your institution as well? Is that one of the reflexes in this day and age is we just jump to molecular? Okay, so no brave souls today. So maybe I'll just continue on, because we're using this as a case because I think it's still a matter of a debate whether should you do molecular for screening purposes. And in this case, in this young female, it does return with the presence of a JAK2 V617F mutation. So the second part here is, is there enough information? Is it actually a myeloproliferative neoplasm at this stage? Or do you like to see what happens in the bone marrow first? Might just be you, just me and you, Sadaf.
I think so. Yeah, I would like to, marrow this patient and see what's going on, because, the presence of JAK2, and it is, but I wanted to know what's the RAF. And yeah.
And I think there's also, I think we're entering the age of the terminology as well. Is it enough to have a PCR result to be the same as the diagnosis of a neoplasm? No, we're using JAK2 here as a special case, but with relatively trivial leukocytosis and thrombocytosis, is that enough to really, provide the label myeloproliferative neoplasm? Nevertheless, the next stage is bone marrow. And again, just having returned from ASH, there are many other jurisdictions looking at using molecular to be a first screen and using the results of that to determine whether or not a bone marrow should be warranted or not. I know we've had some brief debates at the level of CAP-ACP last summer about that as well. I'm sure there'll be another area of discussion. So this bone marrow really didn't have anything morphologically to comment on. It looks absolutely normal. And one of the questions now, since it was the topic about WHO versus ICC, and I thought maybe it's a good time just to say, okay, if it doesn't actually have any classical features of an MPN, do you still put on the label MPN unclassifiable? So I put up the ICC version here, and you can see on the top line that one of the criteria is that you have clinical and hematological features of the MPN are present. Now, in the ICC version, there's not as much clarity about, well, what exactly does that mean? Criteria number 2, in this case, JAK2, has been met. In the ICC, they do point out more specifically that they would like JAK2 V617F assays to be extremely sensitive to the point that they're even less than 1% analytical sensitivity. They again don't go into a lot of justification for why that is required, because certainly that is well into what we would say clonal hematopoiesis or even MRD levels of JAK2. We have the usual exclude that this isn't other bona fide myeloid disorders, and they say that you need all 3 of these criteria. If we flip over to the WHO version, you can see that there are some similarities. I think it's helpful here that in the first criteria where there are features of an MPN, and again, the terminology is a little bit different, MPN unclassifiable versus MPN NOS. I don't think there's really a need to have changed the terminology in this sense, but nevertheless, they do provide some examples of what these MPN features might be. So is there splenomegaly? Is there atypical thrombosis? And again, atypical is not necessarily unprovoked thrombosis. Is there leukocytosis? And then if we want to exclude, say, monocytosis or eosinophilia, since that would kind of put us down a different rabbit hole. To my knowledge, though, I don't think the WHO, at least the last time I've checked it, in whichever version it is online now, they didn't actually define what the value of leukocytosis would be. Is this anything transiently above normal, or how long it may have to persist? Some of the rest of the criteria there are shown below. And again, some similar guidance to how we would previously have used MPN unclassifiable, try to explain why it might be going into this category. So in terms of this case, we did have a bit of an internal debate about how to explain this. As usual, the more that you write in your sign out, the more non-clarity there may be among us and as well in the literature. And so here we do acknowledge the initial screening PCR result from the blood using a highly specific allele-specific PCR result. On the actual bone marrow, we also repeated that. It was actually, I think, early in our days of myeloid NGS, and it was actually below the filter threshold. So initially it was actually not reported, although there actually were reads about approximately 1.5% VAF. However, we were confident about that result, having also tested that with an orthogonal approach. At the time of the actual bone marrow, there were no cytoses on the CBC. And as I've mentioned, there were no morphologic findings of MPN. So, we didn't feel like this warranted an MPN unclassifiable label at this time, and that we favored that this was more JAK2 V617F clonal hematopoiesis. You can argue that that's supported by the very low VAF. However, we did say that such patients should be continued to be monitored, as the natural history of JAK2-CH or clonal hematopoiesis is unclear. And we know information about this is is still evolving, because it's not just about the lab and the interpretation, but what do we do with such patients? And certainly there are many clonal hematopoiesis clinics that are now starting to accept patients. I know in the Toronto area, there's definitely one already available at UHN, and just showing a few abstracts or papers here on the left about the inflammatory risks of having JAK2, but also, I guess, from a more pathobiological perspective, that one of the models of MPN evolution is that the acquisition of what we quote unquote may say driver mutations can be acquired exceptionally early in life, to the point that they are pediatric or even neonatal. Again, this is just using some modeling techniques. There's also some controversy, I would say, in the field when we rely on VAF quite a lot in some of these myeloid disorders. But in terms of what is actually proliferating in the patient, this may not really be contributing to the VAF if we're talking about the red cells or the platelets. I think the point here is, again, to establish forums for discussion and consensus when such cases arise. Sadaf has some experience with that, as having joined our consensus rounds along with some other community partners. Okay, that's the last. That was the first case. Is there any questions about that?
Hubert, I have a quick question. I had an impression that clonal hematopoiesis is mostly in elderly patients. Do we have an age category where it's more common in an age category versus another?
So this field is, again, continually evolving. So I think the general consensus is if you sequence deep enough, all of us have clonal hematopoiesis right now.
Okay, so
But
it's not age determined, not age
yes.
determined.
So clonal hematopoiesis can be going quite early. And again, it's going to boil down to what's our operating definition of it right now. And certainly some people use a VAF of 2%. JAK2, I think, is very tricky because it's, again, one of the assays that we probably all have at our fingertips that in its design, is already extremely sensitive. So you might know or not know at your institution, right? Who orders the JAK2? Is it just hematologists? Do internists order that if someone has a stroke, if someone has, a clotting disorder? So the more you screen, the more you will find. And if you go with the kind of what some people are proposing, if you screen and you get a molecular result, then you have to do a bone marrow. And if you catch something extremely early, I think you can say that morphologically, we can't really see any changes yet. But is this already cancer? How do you sign that out? Do you use MPNU or do you use clonal hematopoiesis?
Thank you, Hubert.
Hubert, this is Sadaf. So the case that you presented was a younger patient.
Mm-hmm. I think she was 27. 27,
yeah. So, and however, when Sarah was mentioning clonal hematopoiesis that you usually see it in elderly above 65 years of age. And as Hubert mentioned, that it's all depends about the sensitivity and of your analytic tests that you're performing. So how sensitive your test is to detect that. And then what do we do with that information? That's really important.
Yeah. So usually the clonal hematopoiesis associated with aging is more your DTA mutation. So again, it's not quite clear if JAK2 is unique and potentially even more unique than, say, CALR or MIPL mutations. So the more you drill down, I think the more complicated it's going to become. But I don't know if anyone else has come across the same situation where, the marrow looks really normal, but you have a driver mutation.
Yeah. And I think in the new WHO5 that is under the category of age-related clonal hematopoiesis, ARCT, under that category.
Okay. So maybe we have time. Maybe I'll just do one more. Let me see if this is the one. I think it is. Okay. So, so you did an interesting survey, Rosemarie, about, I think one of the questions you asked is who's using which class. Was it who is using which classification system? Did you ask actually who likes which classification system better?
Okay. Yeah, so it was basically which classification system do you use? Okay.
So I think, and again, only speaking from the myeloid side, that there are some operational challenges, I believe, with the WHO one, especially for some of the myeloid disorders. But maybe hopefully we'll have some discussion at the end of this one, maybe. So again, this is a quite an older gentleman now. I mean, he's 93, but he has had pancytopenia with macrocytosis for quite some time. So by the time he came to my attention, he probably has had this for maybe up to 3 or 4 years. I had already had 2 prior bone marrow investigations, one in 2018, one in 2021, and both reported that there was no dysplasia and it was a normal karyotype. So when it came to my attention now, again, low hemoglobin, neutropenia, thrombocytopenia, macrocytosis, and isocytosis, you only need the quantitative elements here and maybe this clinical context that you'd probably agree this really smells like myelodysplastic syndrome. Would you agree? I'll take your silence as the resounding yes. This is almost like some of the case-based learning that we do at U of T back during the pandemic when all our medical students don't say anything, but no worries, because it gets quite interesting because again, two bone marrows have already occurred. No dysplasia. Again, here's some just textbook images, but I'm saying that this is not what it looked like. But this has been pancytopenia for a very long time to the point where the patient requires transfusion. And on this third marrow, again, it doesn't really look dysplastic. And I really wanted to make sure with my colleagues, and again, they agreed, you know what, there's just really almost no dysplasia in this marrow. And the karyotype came back normal again. Blasts are not increased. Now, this was prior, for those who are in Ontario, to myeloid NGS being funded by Cancer Care Ontario. But if you had the option to pursue it, in my case, I felt like this is the third bone marrow. This patient should just get what seems to be a clinically obvious diagnosis. So I thought we would get something, but I wasn't necessarily expecting, oh, well, that doesn't look very good. 5 mutations and high VAF, many that are already associated with higher risk. So one of the points I want to emphasize here is, for me, again, a teaching point of the extreme discordance in this case between morphologic dysplasia and what we say, genomic dysplasia. And again, post-ASH, there are many groups working on whether or not this diagnosis can be made just from a liquid biopsy off the blood. The point here, again, would go back to, if you're going to read the Bible here, WHO, 5th edition, beta V2, we kind of come to the consensus that there is no dysplasia. So essentially that leaves us with the diagnosis that this is clonal cytopenia of undetermined significance. That just seems very undesirable to me in this clinical situation. The similar chart from the ICC, again, has clonal cytopenia of undetermined significance. And again, it's defined that you don't have dysplasia, and that still remains where we're drawing that red line. So while, your clinician's knocking on your door, asking you, yelling at you, is it MDS? Is it not obvious? Is it MDS? And we know dysplasia has its limitations because we know there are many other things that can make you look dysplastic. Are there things that can actually make you look normal despite you have underlying MDS? I don't know the answer to that, but in this case, I tried to split hairs here and just to say that the operating differentiation between clonal cytopenia of undetermined significance and MDS is an evolving area. And to try not to get into trouble, I said it was equivocal 10% using our conventional dysplastic thresholds. However, this mutational profile is much more supportive of MDS myeloid neoplasm that this is already neoplastic. This is not just clonal hematopoiesis with cytopenias. And as you can see in terms of the natural history of this patient, that by the time we did this NGS, he would blast off and end up expiring shortly after. So I think the discussion point here again is, what should supersede what? I know we have WHO and ICC guidelines about how we use these tests, how we integrate them. And again, should we be integrating them? Or perhaps, you can go back to say, I report dysplasia and that's it in my bone marrow. The clinician can decide whether or not putting this together mandates MDS or CCUS, and they can manage it how they want to manage it.
Any questions from the audience?
Or we can pick names and bug them.
I think so.
Okay, let's bug our Hempath residents. I see at least a PGY2 and a PGY3. Any comments?
Hi, this is Iran. Very interesting, and as you said, this is an evolving area. I personally have no comment. I'm just learning every point and every case that come along the way.
Well, thank you for being brave. What about our colleagues at UHN? Anyone coming across this now as well? Okay. Well, as we see, as our toolbox continues to evolve, I'm sure these definitions will continue to evolve as well. But as currently set, dysplasia is still something that defines certain entities, even though everyone acknowledges it's extremely subjective, and that 10%, sometimes you're really trying to hunt for 10%. And then we also have the opposite situation where it's probably not MDS at all, but how come these red cells look a little bit funny? I see Larissa has her hand up. Thank you, Larissa. Aren't you on vacation?
I am on vacation, but I thought I would take this opportunity to learn something while I'm on vacation.
Thanks, Larissa.
I was just wondering, these cases, it might be interesting to try and, I know because we're moving into the era of digital pathology and AI, maybe we need to collect these kind of cases and we use them as kind of a way to see whether AI can help us find this subtle dysplasia.
I don't have the reference here, but there are certain publications that have also tried to take, these mutations, the VAF, and tried to correlate, well, which of these mutations actually causes more overt dysplasia under the microscope versus is this happen to be a combination of both epigenetic and spliceosome mutations that then somehow ended up making the cells still look normal. So again, that's still very unusual, but again, there's been some work on that as well. I just think, usually when we're doing these, we don't expect to have that many variants come out when we really didn't look that bad. So for those who are, getting the karyotypes back and getting your NGS results back and looking at your flow and then looking at your morphology and saying, oh, you know what, that really wasn't what I was expecting.
Yeah. Actually, when I was at ASH, there was a couple of posters that I saw where they were linking certain mutations to different morphologic findings. I haven't, dive deep into those posters yet, but I bookmarked those posters to kind of like take a look at them later. Because I think there's a few people doing some work like that to link different mutations to different types of dysplasia.
And I know Mike Rao from Kingston has already looked at these particular patients that, oh, had you just done the NGS back in 2018, this case probably already had many of these. Some of these are probably newer acquisitions as well. Maybe the TET2 was the ancestral one. Okay. That's it for me, Sadaf.
Great. Thank you so much, Hubert, for presenting wonderful and challenging topics. And there's a question for all of us. Okay, so Dr. Kadeep had one presentation, but she had a code red in the hospital and unfortunately couldn't present. So I think we'll end our meeting for now. And thank you so much, everybody, for attending the meeting. You will be receiving the evaluation for this meeting in your email. And please feel free to fill the eval. You'll be getting two Section 1 credits for attending today's hematopathology CUI. I would really like to thank Sarah and Hubert one more time for coming and sharing your valuable experiences with us. Thank you so much and happy holidays, everyone. Take care. Bye-bye.